Okay, this one video is for our advanced EMTs, talking about Cpap placement and then when it's indicated. So likely, hopefully you will, for sure, as a student of mine, have your stethoscope with you. You may be entering a home. Fred here is going to be in a tripod position. Now again, tripod position is generally the hands on the knees and they're, excuse me, leaning their hands forward and then increasing the circumference of their chest in order to be able to expand their chest and take bigger breaths. So he's tripoding, he's doing that pursed lip breathing of, which is the poor man's way to increase the PEEP when you're breathing. These things alone may not warrant you to do CPAP, and that's why tripod, pursed lip, I put maybe a depending on the patient. COPDers will normally have some distress where they're tripoding and they'll have that pursed lip breathing. So it's really going to be dependent on whether you can rectify that with nebulizers or just simple increase of FiO2. The oxygenation may make that stop. So that's a consideration. If I see a patient like this, I know they're in distress, but whether they're in distress enough that they're moving into failure where we need to intervene is the question. So tachypnea, fast breathing rate, the body's trying to compensate, trying to equal out the levels by breathing faster. Diaphoresis, we know that pale, cool, clammy skin is a sign of some sort of shock that the patient's going into. These are the underlying ones where we're definitely going to be looking for CPAP placement. 1 to 2 word sentences. If a patient is unable to talk very eloquently, then we're very worried about their ability to retain air to push through their vocal cords to be able to speak. So that would be an indication to me of some severe respiratory distress. Altered mental status is the last sign and symptom that you'll see before a patient goes into respiratory arrest. So they may be in failure already where the chemoreceptors are experiencing high amounts of CO2 and low amounts of oxygen. That would be a respiratory failure because their body has failed to oxygenate itself or to maintain that carbon dioxide level. We don't want him to go into arrest though. So if a patient has an altered mental status coinciding with difficulty breathing, definitely get a CPAP on them as soon as possible. If not, be prepared to place an advanced airway because they're going to stop at some point. Their body's now failed to oxygenate their brain appropriately. Lower SpO2 is kind of, a given again. If we can do it with just supplemental oxygen and increase it, then that's great. We always want to move from least invasive to most invasive. But we do know that CPAP is going to affect 2 of the factors that we can affect oxygenation, which is FiO2 and PEEP. So if they need more oxygen than what you can give via non-rebreather, certainly put this on because it will help with the carbon dioxide levels too. The question becomes, is it solely an oxygenation issue or are they not breathing adequately enough that it's also a hypercapnia issue? If their CO2 levels are also high and their oxygen is also low, then you need to move to this. But if it's just simply as they're supposed to be on supplemental oxygen and it ran out and they're not on it, they're breathing adequately, good rise and fall of the chest, good respiration rate, they just need that supplemental oxygen, then you don't necessarily need to reach for this right away because you can fix that by giving them that high flow oxygen. Fred here needs oxygen, so what we're going to do is assemble our tubing and then this would connect into the machine, which is going to produce that high pressure flow of 100% oxygen to the patient. In the case of, especially now, but really in any case you want to, you can apply a filter either here or in between that will help, contain any of the particulates coming from the patient. And then we're going to make sure we have the right face mask measurement. So a lot of times you're going to see these going into the eyes and smushing the face, but we want to get a good seal around that bridge of that nose and then around the chin as well. So then you can tell if the patient's face is getting swallowed or if it's just barely covering the mouth and the nose of whether you need to go up and down a size. You should have either sizes 3, 4, and 5 or small, medium, and extra, or large, available to you. Now what I said before, sometimes a good life hack is to attach these loops into little protruding columns there, partially before you're connecting it to the patient. So then I'm going to push it on there. As soon as I push it on there and maintain that seal, Fred here is going to be starting to get some positive pressure breaths, and it's going to help increase his tidal volume. He's going to be able to breathe a little easier. So as long as my hand's there holding it, then you give yourself some time. So now I'm going to reach around and I'm going to connect that one. That one's broken. And then I'm going to reach around and then connect the other one. And what we're looking for here is once they're all connected, we're going to feel around just for any escaping air. If you feel escaping air, there's not an adequate seal, or you might hear a whistling around the mask, and you're going to need to readjust it. If you had Fred on a high flow nasal cannula and you put this over and you hear that leaking around the mask, you need to take the nasal cannula off because that mask is not able to seal. It depends really on the Cpap device, whether or not you're going to be able to keep that nasal cannula on. You can certainly do it if your patient is in a pretty severe respiratory status where their sats are, say, 60% despite high flow oxygen, and you know that this is 100% oxygen, but you want to do the double whammy, so you can put a high flow cannula in and give this for double supplementation. So that's the basics of Cpap. Again, we're going to be looking for sure for altered mental status, 1 to 2 word sentences, shallow breathing, so poor rise and fall of the chest, in order to put the Cpap on. The way that it's affecting oxygenation is because it's increasing the amount of inspired oxygen. It's increasing the expiratory pressure, or the PEEP. So those are the 2 ways we affect oxygen. And the 2 ways that we affect carbon dioxide are the tidal volume, or the amount of air we're breathing in, and then our respiration rate per minute. Now this, we cannot set for a certain rate per minute, but as patients are able to take in deeper breaths, their body's going to compensate less, and then their respiration rate will naturally go down. So that's how you affect it indirectly with the Cpap machine.